Patients don't come into the urgent care for HIV, and that's exactly why it gets missed. Your MP Pal here. Welcome to another lesson from the track. All right, so for today's segment, I'm going to call HIV in urgent care. The myths you don't see. All right, so in urgent care, if you've been out here working, you know that I would say at least 50% of what we see every shift is upper respiratory. All right, the cough, congestion, the fevers, the flus, the COVID, all of that stuff. And we see it all day long to the point where you can kind of start guessing, or you may even know what it is before you even walk in the room based on just the story, just what they put down and things like that, especially during flu season, where you can tell just by the vital signs, even before you walk into the room, you'll see temp is 103, they're tacky, blood pressure, everything is up. And then you walk in the room and they're laid out, bundled up, shivering, you're like, oh yeah, you got the flu, right? So after so many hours and patients that you've seen the same thing over and over, you basically get conditioned because you've seen these patterns and you know what it is. So, and that's not a bad thing, it's just something that comes with time. It's just, there could be other things that may get missed, all right? Now, of course, we also know that 90% of these upper respiratory infections are viral, all right? And we already know how antibiotics are overprescribed and things like that. So, of course, the goal is to not have to prescribe so many antibiotics. Now, with that being said, this may not even be something that is caught on the first visit, because who's thinking something really, really bad the first time you see somebody, all right? So, when this could be something that is caught is when they come back on that second visit, all right? Which is another common thing. So, the company I work for at the urgent care, they are like not fans of antibiotics and steroids and stuff like that. So, we do have a lot of return patients that come in and will prescribe nasal spray, cough medicine, and stuff like that. It just don't work. So when I see these, this population or these patients, a lot of times that second visit, I'm most likely going to give an antibiotic, because you already know how they do. They'll come in there day 2 and 3 and they're, oh, it's the worst thing, it's this, it's that. And we all know there hasn't even been enough time for that, all right? When they come back, it may be day 7, day 10, or 14. And so at some point, you know, something bacterial could have developed. Even then, like with sinusitis, we know that takes 8 to 10 days to develop, but even at day 7, it's still polyviral, even at 10 days. Most sinusitis is viral, so we all know that. And then even for a cough, like bronchitis or subacute cough and all of this stuff, they can be coughing for 3 weeks, 4 weeks, 5 or 6. That doesn't mean it's a bacterial thing. So even when we give antibiotics, it's still most likely still for a virus, all right? So when you should kind of get concerned during this second visit is that many cases when they come back, they usually have something specific. All right, they may have the sinus pressure, they have the pain and things like that, or the cough and the short of breath, right? So we know that with HIV, they have flu-like symptoms. Now that's an umbrella term, like what falls into that for HIV? So it's usually not gonna be something specific, right? So if you look at it, it'll just say fatigue, malaise, lymphadenopathy, and just not feeling right. So that fits under there. So I'm asking you to pause. If they come back and something just doesn't fit, right? They're not having sinus, it's not cough, short of breath. They're still maybe having like a fever, they're achy, and they just don't look right. Something just doesn't fit. That's when you should pause and slow down, all right? Because of course, you're not gonna just think HIV the second time they come in. Like, that's just too extreme, okay? So I'm saying don't just throw an antibiotic at them. Don't be so quick to do that. And then also don't be so, oh, it's HIV or something crazy like that, okay? So this is where you wanna ask more questions. So let's say they do come back and they're tired and they're something's off. That's when you start to ask more questions, pause and slow down, because you may not get a third visit, okay? Because I know if I went somewhere and I saw them twice and they gave me different prescriptions and stuff like that, I'm probably not gonna go back, because in my mind, I'm gonna be like, y'all don't know what y'all doing. Y'all not helping me, so why would I go back? So you may not get a third visit. So that second visit is very important. So if you are thinking something else, again, if there's an HIV, something chronic, something underlying, then yes. So ask about any recent exposure, any new partners, or some of these viral symptoms that just don't fit into any other category, all right? So again, if you get a yes on one of those, then that leads you to something else. And that's another thing I'll talk about, my systems and frameworks. So for HIV, I came up with think, test, act, refer. And the reason this is all even coming up is because there's still 30,000 plus cases of HIV diagnosed per year, all right? And working in urgent care, we see everybody, all right? And we know how there's a shortage of primary care providers and things like that, or even patients with PCPs, they can't get in for 2 or 3 weeks. So it's more easy and convenient for people to just walk in and be seen. Now, again, we have an opportunity. So we have a lot of things that may pass through us. So we have an opportunity to catch some of this, okay? Not to say we're gonna catch it and start treating and managing, but if we can at least think about it, all right? So that's the first letter of the T. So think. You ask them questions, they just don't look right, something feels off, weight loss, anything, just add it to the list. If they don't fit the typical picture of just a normal upper respiratory infection, okay? So the next thing is after that, if you're thinking, you're suspecting, then test, okay? Test them. Of course, you do have to tell them that. So as you're asking questions, they may start looking at you, and I always frame it like this. I'm just trying to cross some things off the list. So if you do even have to go down that pathway, I'm just asking if there's anything, suspicious or anything like that. So, and they may look at you, whatever, but what if you do catch them? What if they have it, okay? So the next is act. So that's if you're actually going to give them something. Now with HIV, there is PEP and then there's PrEP. So PrEP is the preventative treatment for HIV. Honestly, for urgent care, we don't even need to worry about this because that is a preventative thing. And even before you start that, you have to test them and make sure they don't have it first. So I just want to throw it out there so that you know what it is, but not something that we have to worry about in urgent care. The other one is PEP, which is post-exposure prophylaxis, okay? So with this, that is typically if they come in within 72 hours, like if they had a sexual encounter with somebody, not even just sex, even like IV drug users, but if something happened and they come in within 72 hours, the CDC actually says you can get this if it's been within that time frame, okay? So, and then refer. So if you get to that point, this may be something that if you do test them and then it comes back positive or something like that, then you refer them out. So not all of these are during that visit, but just follow those steps, okay? And again, our job in urgent care is not to manage. I'm not suggesting management. No, we're not gonna start treating this population. But if we don't do anything else, at least if we can think about it and then test them, that will drastically change outcomes and maybe even catch more cases, but also not let this thing linger and get somebody on the proper treatment much sooner, okay? And that's pretty much it, okay? So just remember that it's the second visit, that you may have to slow down, pause and think, and go down a certain path, certain questions if something just doesn't fit right. And think about it, test them, and then send them out, all right? And that's pretty much it, okay? So again, just a simple framework to consider HIV, because we definitely want to ensure that if you do have a patient with this, that they are tested and that they get on the proper treatment, okay? All right, as always, your MP pal here. Think clearly, practice boldly, and I will see you on the next one.